Hi, this is Elliot Fishman, and welcome to part 3 of our talk on serous cystadenomas. Now, we left off before looking at calcification. Now, it's important to recognize that calcification in pancreatic lesions is not uncommon. Mucinous cystic neoplasms, peripheral or central calcification. Neuroendocrine tumors can have central calcification. Often it's fairly coarse and can be substantial. SPENs can have calcifications in the gland, around the periphery, or both. IPMNs can have thin linear calcification, and occasionally metastasis, depending on the primary, can have calcifications, though it's pretty rare. So in terms of numbers, up to 25%, some articles say 30% of serous cystadenomas can have calcification. You can see SPEN probably leads the group, up to 50%, but each of these lesions can have calcifications. So what I'd like to do in this part of the talk is show you a range of calcifications and how the calcifications can be very helpful in helping arrive at the diagnosis in many of the cases. So here's a cystic lesion in the tail of the pancreas with coarse calcifications. You can see it very nicely on the coronal views. Again, the lesion, if you look at, there's no dilated duct. It's low density, but if you look hard, perhaps there are septations. But that coarse calcifications makes you think about serous cystadenoma, though it's not specific. This case, I showed you this in part before, a large cystic lesion, some rim-like enhancement, a dilated pancreatic duct, glandular atrophy, and coarse central calcification. We talk about this lesion as a stretching of the vessels, draping of the vessels around the lesion, the fact that as you go from arterial to venous, the cystic components are better seen, the fact that you have rim-like enhancement, which is stretched vessels rather than tumor nodularity, and the fact that you do have some calcification centrally, though this is a good example of very minimal calcification. We talk about the classic central stellate calcification of serous cystadenomas, and this is not one of those examples. When you have that stellate central calcification, it's more extensive. And here's just the venous side of that lesion. Again, serous cystadenoma. Now here's an easier one. Large cystic lesion, no dilatation of the pancreatic duct, multiple cystic lesions, so they're over 2 centimeters, kind of that macro component. And then you see lots of calcifications. It's not just central, there's some peripheral. You can see on the venous phase the draping, and arterial phase the draping of the vessels, and the very coarse calcifications present. Nicely shown especially on the MIP imaging. Here it is on the sagittal view, and here it is on the coronal volume rendered on your left, MIP on your right, and again, very coarse central calcification. When you see coarse central calcifications and the calcifications are this extensive, I think serous cystadenoma needs to come front and center to your thought process, though I will admit you can get central coarse calcifications that are extensive in neuroendocrine tumors, but invariably those neuroendocrine tumors are also going to be very vascular. Okay, another example. Complex cystic lesion, large and small cysts, lots of calcification being distributed throughout the lesion. I think a combination of the cystic lesion appearance and the calcifications make it fairly easy for you to make the right diagnosis of a serous cystadenoma. Okay? Classic. Here it is on the volume rendering as well. So small cysts, larger cysts, calcification. Not hard to end up with serous cystadenoma as your primary diagnosis. A classic case. Same thing here. This looks like a case I showed you a few minutes ago. Cystic lesion, large and small cysts, very coarse calcifications, kind of a stellate-like appearance. I'm kind of hard-pressed to think about any other diagnosis. We mentioned other things that have calcification, but this is now not how an MCN would look. It's probably not how a neuroendocrine tumor is going to look. This is also a good example showing you the scalloping along the portal vein in SMV. But to me, the cystic lesions with the coarse calcifications, that really prominent, what looks like a stellate calcification, as good as it gets, really pushes me to a serous cystadenoma. Now here's another one, large complex cystic lesion, small cyst, large cyst. I think you're thinking serous cystadenoma and the calcifications help you. I show this case because the patient also has splenic vein obstruction. Now it's important to recognize that even benign lesions can cause vessel obstruction. I showed you and mentioned how typically scalloping of portal vein and SMV can be seen with serous cystadenomas, but I don't typically see obstruction. Every once in a while, you can have splenic vein obstruction. And the splenic vein obstruction is because the mass is just so large, it compresses the splenic vein. But here again, the coarse calcifications, just like those other recent cases, really pushes you to serous cystadenoma and very impressive collateral vessels. Here's another case. This is kind of interesting. When you look at the images quickly, it almost looks like that's the spleen, but that's the tail of the pancreas with, again, those coarse calcifications. As you look at the full sequence of images, coarse calcifications, and you recognize that this is coming off the pancreas, particularly well shown on the coronal view. The spleen is up higher. You really don't see it. But very coarse calcifications. Yes, there is somewhat of a thickened wall, but you got to be thinking about serous cystadenoma. I could consider a neuroendocrine tumor, but again, the coarse calcifications to me are just something that pushes me to serous cystadenoma. Very nicely shown in this example as well, on both the coronal and sagittal. And again, the cinematic rendering is very helpful. Another example, complex cystic lesion, multiple cystic lesions, many of them small and with punctate calcifications. I think without the calcifications, you should say serous cystadenoma. When you add the calcifications on board, I think it makes it easier. Now, this is not those coarse calcifications from a few seconds ago or the stellate calcifications that we just showed you. It's more of the tiny punctate calcifications. And I put this case here to emphasize the range of appearances. It's not just simply calcification or no calcification, it's the pattern of calcification that could be helpful, but is very variable. Again, cinematic rendering, a really nice example showing you the individual cysts. Remember, cinematic rendering provides texture mapping, and that texture mapping shows the vessels, also nicely shows the cystic lesions, and the extent and variation of those cystic lesions. Again, this makes it easy for us to conclude what specifically the diagnosis is. Another example, this looks almost like the lesion I showed you a moment ago in the tail of the pancreas. Large cystic lesion, some septations. It's more between a macrocystic and oligocystic. Maybe you have to call it macrocystic. But look at those coarse calcifications. Often MIP with projection makes the calcifications seem like they're in one plane because that's a typical MIP projection technique issue. But it shows very nicely the coarse calcifications, also the patency of the hepatic artery and GDA and how those vessels are draped around the lesion, and how the coarse calcifications within this cystic lesion are so nicely shown. Now, the last thing I'm going to address in my talk is just one of the differential diagnosis. I mentioned at the get-go there are many things that we need to differentiate in cystic pancreatic lesions. But I'm going to talk about one of the most difficult is distinguishing between a serous cystadenoma and a neuroendocrine tumor. This can be very difficult because, first of all, we showed you some vascular solids serous cystadenomas. Those are impossible almost to separate. We talk about vessel encasement with neuroendocrine as opposed to draping with serous cystadenoma. We talk about the lack of nodes, surely enhancing nodes with serous versus what you typically or commonly could see with neuroendocrine tumors. And of course, clinical presentation can be helpful. Now here's an interesting lesion. When you look at it quickly, there's lots of enhancement. You see the vasculature. There's no neovascularity. The vessels are stretched. The GDA is patent. As the lesion washes out on venous, it's better defined, and the cystic components perhaps better seen. On the coronal view, the borders of the lesion are perhaps better defined. The duodenum is unremarkable. And although at first glance I was thinking neuroendocrine versus serous cystadenoma, the more you look at this, the more images you look at, the more likely you are to say serous cystadenoma. Okay? What about this case? Look at this lesion in the junction of body and tail of pancreas. This was rule out dissection, and the aorta is great, but look at that cystic lesion. There's rim enhancement. Could this be a cystic neuroendocrine tumor? There's no dilated pancreatic duct. There's no adenopathy. There's no liver lesions. As you go to venous phase, the lesion is well defined. It's a little bit eccentric. There's enhancement and thickening of the wall of the lesion. I do have to admit a cystic neuroendocrine tumor is a very good diagnosis. They're often in the 2-3 centimeter range, as they can be small, and they're not uncommonly incidental findings. You can see the lesion here on the cinematic and here as well, and I think this is a very tough case. This ended up being a serous cystadenoma with a VHL mutant seen on the EUS sampling, but I have to admit I would have thought about a cystic neuroendocrine tumor, and I don't think you could make the diagnosis and just say serous cystadenoma, next case. Another patient, weight loss, very similar to the last case in terms of location, but doesn't quite have the vascularity. It kind of looks cystic, and so here again is maybe not the most classic serous cystadenoma, but I would feel less likely to worry about that being a neuroendocrine tumor. What about this one? This looks almost like a few of the other cases. It's somewhat cystic. The vessels are draped around the lesion, but the lesion does have vascularity. So again, I could be thinking of a neuroendocrine tumor. One of the things with neuroendocrine tumors, they could be better defined on later phase imaging with better margins, but the same thing is true with serous cystadenomas. You could see it's somewhat challenging. There's no dilated duct. Could be serous cystadenoma, but I could not rule out a cystic neuroendocrine tumor. This would be sampled, and the diagnosis was a serous cystadenoma. So again, showing you some of the complexities of this case. And here's very similar to the prior case, except the lesion is larger. There's draping of the vessels. There's some enhancement. There's some cystic components, but there's some vascularity within the lesion in addition to stretching the vessels. And here's the third case, which just shows you a similar thing, but just larger. Now, neuroendocrine tumors can be small or medium-sized or very large. This case, I think, we showed before, we spoke about the calcification, but again, calcifications could be in neuroendocrine tumors or in serous cystadenomas. But in this case, I feel better about the stretching, and in a larger lesion, sometimes I feel more comfortable being very specific of the diagnosis, and I think the smaller lesions can be a little bit more challenging. So again, this was a serous cystadenoma, but I could understand why you'd be thinking about a neuroendocrine tumor. So we've gone through a lot of different things. I've showed you some of the classic appearances of serous cystadenoma, and I've showed you many of the less than classic or atypical appearances. We spent a bit of time on differential diagnosis. We showed how many lesions are incidental findings, why others patients have abdominal pain or weight loss, and your concern will be different. And we talk about clinical management. When do you need to do EUS to sample a lesion, when you can simply say benign, leave alone, and when you need to do something a little bit more, including EUS. There was an article just a couple years ago talking about cystic pancreatic neoplasms by Kim and Castillo. Just to review some of the points, serous cystadenomas are non-mucinous benign neoplasms of the pancreas, which can be observed rather than resected. Cyst lining is composed of glycogen. The more common microcystic variant is composed of numerous small, under 2 centimeter cysts, that typical honeycomb appearance, while less common oligo or macrocystic have a different appearance and can be more challenging in reaching the correct diagnosis. We talk about the age level. It's more of a higher age than mucinous cystic neoplasms. It's more common in women. Half present to 2/3 present with symptoms, abdominal pain. Other times it's incidental. We mentioned that it's more common, or it's commonly seen in von Hippel-Lindau, which is very rare. And even in von Hippel-Lindau, only about 7% of patients will actually have it. And again, the fact that these lesions have a less than 1% chance of malignancy means, particularly in patients who are high risk because of age or other complications, if we can recognize these lesions, they can be left alone. So again, it's very important to recognize that. It's also important to recognize that these lesions can grow. They can grow up to 3 millimeters a year. When lesions grow more than 3 millimeters, we then begin to worry. So we've gone through everything. We've thought about the differential, and you should think about main duct IPMNs and side branch IPMNs, the exophytic lymphoepithelial cyst, and the septated mucinous cystic neoplasm, and the complex cystic and solid and calcified SPEN tumors, and then take us to that classic serous cystadenoma. I hope we've helped you think about the variability. And I think what I'll do is I'll come back again at a later date and maybe take mucinous cystic neoplasms and show you a range of those. I think it's important to not just read the text, but look at images. And I think hopefully we've showed you a lot of cases. And with that, I thank everybody for their attention. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.